the world. Like he's an individual having maximum score till now in the world. Okay, so he got 260 on his step 3 and 276 on his step 2. Okay, we also have Dr. Abdullah Humayun, who is like a trainee at Mayo Clinic. So he'll be helping you throughout your research process and getting your publications in best journals. Okay, so the services which basically we provide in this platform are USMLE step 1 marathon. That is going to be 120 days marathon. Okay, so the marathon is basically our unique idea which we brought to the market, and a lot of success story. We have like more than 95% of passing rate with that. Okay, so we also have marathon for step 2. Again, it will be for 120 days, and we also like provide services for one-on-one tutoring. Besides that, as you guys know, that if you want to get residency in US, you at least need 3 of the publication, right? And that should be meta-analysis. You guys know that meta-analysis just take a lot of time, but don't be worried. Our mentors are going to help you with that. We have like a proper research wing. They're going to help you with your publication. And besides that, those who want to have opportunity for your US clinical experience, ERAS application, mock interviews, and CV building. Okay, so once you're affiliated with this platform, our goal isn't only to get you prepared for your step 1, but you'll be following us for the next you would say 8 months, right? So in these next 8 months, we guys are gonna prepare you for your next match cycle. That is 2027. Okay, if you guys recruit over this program, and with that, we'll also be doing research. So we'll just make you sure that you have at least 3 publications. Okay, which is like important for your CV once you get your interviews. Okay, so let me just give you an overview how our 120 days marathon for step 1 look like. This 120 days marathon, basically we have divided it into 2 phases. So the first 90 days are going to be your phase 1. Hello? Yes, any questions? Okay, so the first 90 days in these 120 days marathon are going to be your in-depth study of your resources. That is your first aid, your U-World, as we have mentioned, and you guys are going to have live interactive sessions, right? So we have like Dr. Maheen, as I just told you, she's internal medicine resident, first year at Oklahoma. She'll be helping you with your U-World, like at least doing 30 to 40 MCQs. She'll be just telling you the strategies, how to do U-World. So you guys are going to join our live session, and she'll be having live discussion over U-World, right? So once you guys are done with your U-World session, then you guys are going to have interactive classes with Dr. Muaz and me, okay, Dr. Ahmed. Okay, I'm Dr. Ahmed, by the way, okay? Okay, so right after that, we guys will be giving you 1 hour of break, and right after 1 hour of break, you guys are gonna have your discussion on your Discord server. So we have built Discord server for students, and we have divided like the groups in based on their time zone, so you can just connect with your mates, and you can just, they're gonna give you motivation, because like, it's a time-consuming journey, and most of the students get drained out. So for that, we have like the specialized way in order to keep you on the track and keep you in the loop. Okay, so we also have collaborated with Official U-World. So those who want to purchase, we are going to Official U-World, we are going to give you like discount codes for that as well. Okay, and like we'll be starting from cardiovascular, and we'll be covering entire things like cardiovascular. Right after that, in our schedule, we'll be doing endocrine. After endocrine, we'll be doing renal like hematology, all of the main system. And after the main systems, we'll be doing the minors. So the minors would include your biochemistry, and along with that, we'll also be doing a revision session. Okay, so biochemistry, your biostates, and all of these things. So all the classes are going to be same till the end of your 120 days. Okay, and in the end, once we just as we know that right after completion of one system, you guys are going to take an assessment from you guys, like in this boot camp which we are just taking today, this workshop. In the end of this workshop, again, you guys are going to have like assessment, right? So we basically keep track of that assessment, and based on that, we can have an idea either you are prepared for your step 1 or not. Okay, so the question bank which we use for assessment are basically made by these experts from NEXTGEN USMLE, right? So they are way more comparable to your real exam. So just focus on those assessments as well, right? So in the end of these 120 days session, we'll be taking NVME, and NVMEs would be taken in a real exam environment, right? So once you just feel that you are prepared for your step 1, you guys can just give your step 1, and right after that, we'll just give you 1 week of break, and right after 1 week of break, you guys are going to enter 120 days marathon for step 2. Okay, and in this way, once we are done with step 2. Along with that, the research process is going to be, we are going to carry it along with these schedules. So we have just put the research schedules quite lenient. Like if you are only giving a list time, like that is half an hour per day, so that's more than enough for you to get like meta-analysis 2 to 3 publications. Okay, so here is the daily schedule which we are going to follow in this 120 days marathon plan. That is 1 hour session with Dr. Mahin, you will discussion as we mentioned, regular session with Dr. Muaz, and I'll be just having a review session. Like once we are done with our system, so I'll be just revising the entire system within 5 to 6 hours, and after that you guys are going to have your assessment. Okay, and after that, as I just mentioned, you guys are going to have 1 hour of break, and right after that you'll be having a Discord sessions with Dr. Taha. He'll be there in Discord. He'll be monitoring you guys and the remaining MCQs. If you guys just want to do revisions, all of those things are going to be done in the Discord. Okay, so this is the daily task which we guys are going to share on daily basis. So here you guys can see, like we are going to give you a selected topic, so you only have to like put in 2 to 3 hours of efforts per day in order to do this complete task. Okay, so you guys can see it is one of the tasks from our reproductive module, like early embryonic development. These 3 topics you guys are going to do that. If you are facing any problems, you can also refer to the videos like boot camps or board and beyond, right? And you guys can see here in the end we have UWorld question IDs. Okay, so let me just mention that all of these question IDs are extracted from UWorld, so they are highly resembles the topics which we are giving you, right? So you guys are only going to copy these question IDs, go to your UWorld official subscription, just click on the custom mode, just paste this question ID, and you guys are going to have a personalized a blog for you. So daily question basically includes doing like 30 to 35 questions per day. Like initially we'll be starting only from 20 questions. As you guys are like keeping with the pace, you'll be increasing the number of questions. So till the end we'll just make sure in order to have 2 passes of your UWorld at least. Okay, so these are the assessments which I just discussed, that at the end of system you guys are going to have an assessment with a proper software. So these are the results. You guys can see our students currently are doing very well. So let me mention the batch which we are going to start from 1st May is going to be 3rd batch of our marathon plan. Okay, yes. So here you guys can see the research program as well. Research program again is divided into 2 phases. We have experts from Mayo Clinic and John Hopkins. You guys are going to see them. Okay,
Hello,
so in the
sir.
first
Can you
phase, we guys
please
are going
start
to
the
show you the
class?
methodology of, yes please, sorry. Okay, so it's like a last slide, so just bear me for some time. Okay, so these are the things which we are going to help you, like we are going to guide you for the meta-analysis. So again, we have divided that into 2 phases. In the phase 1, we'll be helping you with the methodology of research, and in the second phase, we'll be applying all of the things in order to make sure to have a publication in the end. Okay, so these are our Discord server. You guys can see everything is shared there. We have proper channels there. All of the daily task recordings are also being shared there, so you guys can see it from there. Okay, so let's start our today's workshop. So as you guys know that yesterday we discussed like very important topics, and we just shared video. Those who haven't who weren't able to attend the workshop, they can just look for the videos. But today we are going to continue our discussion. Okay, so
So
we were discussing anatomy. Okay,
I had a doubt regarding
yes please.
yesterday's topic. Sir, can I ask
Mm-hmm.
why most of the patients are asymptomatic in case of patent foramen ovale?
Okay, so we'll be having a question and answer session in the end. Since we get less time, I'll definitely answer your question. Okay,
Okay, sir, thank you.
is that okay? In the end, basically we're having a question answer session. Thank you
Can I
so much.
answer, sir?
So okay, so we'll be starting with anatomy first. Okay, so yesterday we discussed a little bit anatomy, but today's topic which we are going to discuss are very important, right? So they're very high yield. You guys are definitely going to have MCQ on your real exam, and you guys know that these are interactive sessions, so you guys must participate. I'll be asking you some questions, right? So with the anatomical aspect, you must know that you have different surfaces of your heart, you have different borders of your heart, right? So you have heart surfaces and borders, right? So you have different surfaces and different borders of your heart. Okay. you must know that the surfaces are like mainly formed by which structures, right? So you have like your anterior surface, your posterior surface of your heart, and inferior surface of your heart. I think most of you guys would know that, so I'll be just asking you a question. Can you just tell me that anterior surface of heart is formed by which structure? Yes, which structure of your heart? Which ventricle? Let me just give you a clue. Right or left ventricle? Perfect. That's right ventricle. Okay. Another thing, can you guys just tell me that most of the posterior aspect of your heart is formed by? Yes,
Left
posterior
atrium.
aspect.
Left ventricle.
Mhm.
Left atrium.
Left atrium. Perfect. Can you guys just tell me about the inferior surface?
Left ventricle.
Both left and right ventricle. Just keep that in mind. Okay, it's very important, and your USMLE is going to test you on these aspects, believe me. And how are they going to test you? Let me just mention that. Okay, as we know that anterior surface is basically made by your right ventricle. So which kind of MCQs are you going to see on your exam? They'll be telling you we have an individual. Kindly just fix your mic, please. Don't make any disturbance. Okay, so they'll be telling you that we have an individual. He had a stay-bound injury between third and fourth intercostal space, right? Between third and fourth intercostal space. They'll also be mentioning that it was a medial injury, that is like, close to your sternum. So their question would be, they'll be asking you that what do you think, which structure of your heart is going to be punctured? Yes, what do you guys think?
Right ventricle.
Right ventricle.
Okay, right ventricle. That's perfect. That's perfect. Okay, so you're gonna see this kind of MCQ, but they can also play with this MCQ. They can just tell you, we have an individual, he is having again stay-bound injury at third and fourth intercostal space, but basically the injury or the stay-bound is directed laterally, not medially. Then what do you think, which structure is going to be damaged? Yes,
The lung.
lung. That is okay. Which lung? Left lung, obviously, right? Left lung. So both of these are your U-World questions. You guys can just see in your U-World. We'll be discussing that in detail in our marathon session as well. Okay, so keep that in mind. In your assembly, they love to test such kind of questions. Let's discuss the posterior aspect is formed by left atrium. We already know that. So how your assembly is going to test you for that? Okay, posterior border formed by left atrium. Okay, so they'll be texting you that, for example, we have an individual, right? And that individual is having atrial fibrillation. We'll be discussing atrial fibrillation in detail in our pathology section, that is tomorrow. But let me mention what is atrial fibrillation. Let me just make it so clear and so easy for you. What happens in atrial fibrillation, like for example, if this is your heart, okay, I'm just making it very simple, okay, in order to have get this MCQ done. So what happened in atrial fibrillation, that basically we are gonna have formation of certain foci, right? And those foci are basically present near your pulmonary veins. We guys know that pulmonary veins drain into your left atrium, and in turn, then the blood is going to enter into your left ventricle, right? So these electrical foci are going to be formed near your pulmonary veins. And what these electrical foci are going to do, they are going to send a lot of impulses, that is more than 200, 300, 400 impulses. And once your atria experience such high number and rate of impulses, what happens? Your atria is going to get confused, right? Your atria isn't able to deal with certain big amount of impulses. So what your atria would do, it would become confused, and it would say, I won't beat. I would just stop because I'm confused. I can't do anything. Okay, what is the normal function of your atria? It have to drain blood into your left ventricle. But as you're having atrial fibrillation, your atria get confused by it's basically bombarded with a lot of impulses, 200, 300, 400 by the electrical foci near pulmonary vein. I'm mentioning that because you have a UL MCQ. They'll be asking you, where do we have these electrical foci? So those electrical foci near your pulmonary veins, just note it down, okay? But as it is, as the atria get confused, it won't beat. As the atria isn't beating, what would happen? The blood is going to accumulate within your atria, right? As it isn't beating, the blood is going to accumulate within the atria. And as we have accumulation of blood, we know it's called as stasis, right? That's called as stasis, right? And whenever we have stasis, yesterday we discussed, we have a triad, Virchow triad. What do Virchow triad say? That if we have stasis, if we have endothelial injury, or if we have hypercoagulable state, then this individual is going to be prone to formation of a thrombus. Am I right? Right?
Yes, sir.
Yes.
Okay.
Yes.
So if this individual is having stasis, what happens? All of the coagulation factors which are present within the blood, they would precipitate down and it would just form a thrombus. And once that thrombus is formed, now this thrombus, if dislodges, it can enter your systemic circulation. It can cause a lot of problem. It can enter your CNS. It can give you stroke. It can give, enter into your your small bowel circulation. That is mesenteric arteries. It can get into your renal artery, giving you renal necrosis. Okay, but here UVerl and NVME want you to know an important thing. Basically, in the left atria, we are going to have a sac-like structures near here, right? A sac-like structure. And that structure is basically known as left atrial appendages, right? So we have an extra sac-like structure within the left atrium, which is known as left atrial appendages, or appendage simply you can say. Remember, they are going to ask you, we are having an individual, he is having atrial fibrillation. So we already know that he's prone to stasis, and that stasis is going to lead to formation of a thrombus. But most likely this thrombus is going to lie within the appendage. Is that clear?
Yes.
Is that clear?
Yes, sir.
Yes, sir.
Yes.
Yes.
Okay. So you have a UVerl MCQ. They are going to ask you, okay, just give me 1 second, please. Okay, I need 1 second. Hello? Can you guys hear me?
Yes.
Okay. So you're going to have a UVerl MCQ. They'll be asking you, we have an individual, he's having atrial fibrillation. In which structure within your left atrium, this individual is more prone to have your thrombus? That is going to be your left atrial appendage. Is that clear? Just note it down on your first head, okay?
Yes.
Hello?
Yes.
Perfect.
Yes.
Okay. So let
Yeah.
me just give you an overview of what we discussed, okay? It's very important topic, and a lot of students basically do not know what is atrial fibrillation and things. So I'm just getting deep into the concepts so that you guys can follow. So we discussed, we have atrial fibrillation, and right after atrial fibrillation, what happens? Basically, the electrical foci are going to be present near your pulmonary vein. One of your UVerl MCQ, just note it down, your NVME MCQ, right? Okay, so if you have electrical foci, your atria get confused, it won't beat, it will just stop. As we have stoppage of your left atrium, blood is going to have stasis, and stasis can lead to thrombus formation. Where this thrombus is going to lie? Important, one of your NVME MCQ is going to lie within the appendage, right? And what's the problem with that? It can dislodge, it can either enter the CNS, giving you stroke, it can either get into your renal system, renal circulation, giving you renal necrosis, or either it can get into your, yes, small bowel circulation, mesenteric artery, okay, giving you small bowel ischemia. That's perfect, okay? So as we are having stasis here, so one of the things which you guys must know, that what happens if you are having stasis, blood is going building here. So what would happen? As the blood is building, your atria is going to enlarge. That's a common sense, right? As I'm just filling in a lot of air within the balloon, so balloon is going to enlarge. So same is the case here. If I'm having a lot of stasis, left atrium is going to enlarge. Can I say that?
Yes.
Perfect.
Yeah.
So let's just move over this point. And another point as well. Here lies our which valve? Bicuspid or tricuspid valve?
Bicuspid.
Tricuspid?
Yeah.
Bicuspid.
L8-12 mitral valve, bicuspid.
Mitral valve, bicuspid. Perfect. If we have bicuspid stenosis, let's suppose if we have stenosis, What do we mean by stenosis? That it's hard for this valve to get open, right? So if it's hard for the valve to get open, again, the blood can, stay within your left atrium. Left atrium can enlarge. And as we discussed, that left atrium is going to make the posterior aspect of your heart. So can I say that with both of these conditions, atrial fibrillation or with the mitral stenosis, what happens? Can I say that the posterior aspect of your heart is going to be enlarged? Can I say that?
Yes.
Yeah.
That's perfect.
Yes,
But here
sir.
lies another concept of your USMLE. If the posterior aspect of your heart is enlarged, let me just draw your heart. Okay, so let's suppose this is the posterior aspect of your heart. Let's suppose this is the anterior aspect. This is, the anterior is basically formed by your right ventricle, and this is the posterior aspect. What lies behind the posterior aspect? What's this structure?
Esophagus.
Esophagus.
Esophagus. Esophagus. That's perfect. You guys are so perfect. Okay. So if here lies esophagus, so can I say that if we have atrial fibrillation or if we have mitral stenosis, so due to enlargement, your esophagus can be compressed. It would present as dysphagia. Can I say that?
Yes.
Yes.
Yeah.
Perfect. That's perfect. Just keep that in mind. And what else? How USMLE can also test you in another way. We have an individual. We want to take the pictures of posterior aspect of your heart. Take transesophageal echocardiography. What is transesophageal echocardiography? As the name indicates, echocardiography. We are going to take pictures of your heart from here through esophagus. So what are we going to do? Simply, you can just keep in mind, we are going to insert a small camera at mid-esophagus level, high yield. Keep that in mind. You have a UWorld MCQ, they'll be telling you. As researchers were performing transesophageal echocardiography, they reached the middle aspect of the heart and they were just pointing towards this aspect. So what do you think? We are going to have clear picture of which structure of your heart?
Left atrium.
Posterior.
Left
Posterior one.
atrium. That is posterior aspect. That's perfect. Just note it down. One of your UWorld MCQ, very high yield. But they can also play with you. They'll be just telling you in the other MCQ, if the same camera is, rotated 180 degree backward. Now the face of the camera is here. So now which structures are we going to have?
Aorta.
Descending aorta.
Yeah, descending aorta.
Descending aorta.
Perfect. So we are going to have descending aorta, right? Both of these are your UWorld MCQ. You must know that how the USMLE play with different concepts. Is that right?
Yes.
Yes.
Okay, that's perfect. So let's refer towards our slides. Okay. So I'll be reading these slides. Everything is going to be like quite simple for you guys. So you have right atrium. We know that the right border of your heart is formed by right atrium and right ventricle. Okay. I'm discussing about the borders. The left atrium basically is going to contribute to the posterior border of your heart. We already know that, right? Left atrium. Correlation, enlargement lead to cardiovascular dysphagia. We discussed that. How do we have that enlargement? We already know the concept. Atrial fibrillation can do that. Mitral stenosis can do that, right? Hello?
Yes.
Are you guys following?
Yes.
sir.
Perfect. Perfect. So the clinical correlation, we discussed that.
Yes,
for
sir.
transesophageal echocardiography, we already know the concept. If we just, insert the camera till, the mid aspect of your esophagus, if you are looking towards the heart, we are going to have clear pictures of posterior aspect of your heart. That is basically your left atrium. If we just rotate it 180 degree, then we can easily take the pictures of your descending aorta. You guys just told me that, okay? Then, if you have stasis, we are going to have formation of thrombus via left atrial appendages. Remember, small sac-like structure. Perfect.
Yes.
So this was the thing which I was just talking. You guys can see this camera kind of thing inserted. They're just taking pictures of your left atrium. Can you guys just see that?
Yes, sir.
Perfect. If I've just rotated it 180 degree, then we are going to have clear pictures of descending aorta. You guys can see the anatomy.
Yes.
Yes.
That's perfect. So Okay, so for the penetrating injury we discussed, okay, mid left thoracic 2/3 intercostal space, which structure is going to be punctured? Yes.
Right ventricle.
Right
Hello?
ventricle.
Yes,
Yeah.
if it's medial,
Right
but if it's
ventricle.
lateral, then it's left lung, right?
Yes.
Is that
Yes.
clear? Perfect. So now we'll be doing a dual MCQ, and for that, I have to pick someone to just help us do this MCQs. Those who want to participate, please raise your hands. Okay, Doctor. Okay, Doctor. Okay, Dr. Aryan. Dr. Aryan, can you just please turn on your mic? Dr. Aryan. Dr. Reem. Dr. Reem.
Yes,
Okay, that's perfect. Can you just please read this MCQ for us?
I can see. Yes, no.
Yes, now you will be seeing it.
Yes, physical examination shows a deep penetrating wound in the fourth intercostal space along the left sternal border. Smaller lacerations are noted across the face and forearms. Which of the following structure is most likely injured in this patient?
Perfect, perfect. One of the best things which I liked about you, you know how to read your MCQ. So those who are new here, let me just tell you, whenever just you are reading MCQ, just start from the last 3 to 4 lines because all of the information lies there. It's going to save a lot of time for you. If you are confused, then you should just read your entire MCQs. But I think reading this MCQ from last 3 lines, we already know what are they asking, and we already know the answer because we just discussed everything in detail, right? So what do you guys think? Which structure?
Right ventricle.
Right ventricle.
Which ventricle?
Left ventricle.
Right.
Right.
Right
Right
ventricle.
ventricle.
That's
E.
perfect.
And
That's
actually
perfect. Okay.
left lung.
Yes.
Right
Yes, that's
ventricle and
perfect,
left
right?
lung.
Fourth
Yes.
intercostal space.
If it was laterally, you guys can see in the question they're asking you that along the left sternal border. It's a medial, right? Not lateral. So it means
Yes.
that the right ventricle is going to be okay. Here's the picture. You guys can see, right? In it. So if it's medial, it's going to be your right ventricle. If it's lateral, it's going to be your
Left
lung.
lung.
Is it clear?
Left lung.
Perfect. Okay. So you guys are doing very well. And let me just mention it was an exact MCQ of your NVME. So you guys are doing really great. Okay. So let's discuss our arterial supply now. Okay. So we know that our heart is basically supplied by artery. And what's the name of those artery? We basically name it as coronary.
Coronary arteries.
Hello. Hello. Are you guys following me?
Yes, sir.
Okay, perfect.
Yeah.
Okay.
Yeah.
We know that coronary artery basically arises directly from your aorta, right? And as they arises, they are going to be divided into right and left coronary artery. Okay, right coronary artery and left coronary artery. Are you guys following me? Okay. So the right coronary artery are basically going to supply the right aspect of your heart. You know the structures. For example, your right atrium, most of your right border of your heart. Along with that, we already know that the SA node is also present within your somewhere within the right atrium. You guys know that, okay? So it means that the SA node itself is supplied by right coronary artery. And along with that, we have AV node as well. But there is a special thing which you guys must know. I'll be discussing that in the end. We have arterial supply of AV node as well. But that's dependent on the dominant artery. So we'll be discussing what is the concept of dominancy. And right after that, we'll be discussing arterial supply of your AV node, okay? So we were discussing this was your right coronary artery, your left coronary artery. But we know that further we have 2 branches of left coronary artery. Left anterior descending artery and left circumflex. Okay, so you guys are going to be telling me left anterior descending artery is going to supply arterial blood to which structures of your heart? Yes.
IVs.
Left ventricle.
Interventricular septum.
Left ventricle.
Left ventricle. Septum.
What about interventricular septum?
Anterior
Yes,
aspectum.
Okay, please raise your hand those who want to participate. Dr. Khadija, can you just please tell us?
Yes, sir.
It'll be the anterior 2/3 of the interventricular septum.
Okay, 2/3 of the interventricular septum. What else? Mm-hmm.
Sir, the right atrium. Sorry, the left atrium.
The left atrium. Then what does the circumflex do?
The
Supplies the
apex
left
of
atrium.
heart and the anterior border of the left ventricle.
It's going to supply a
Anterior wall.
papillary muscle. I want you guys to be telling me which papillary muscle. Anterior lateral. Anterior lateral. Just switch the name. It's LAD. So anterior lateral. Just remember it like anterior lateral. Okay. So it's going to supply the anterior lateral papillary muscle. We are going to discuss papillary muscles and details in our marathon video since we get less time here. So we will be just continuing that in our marathon daily classes sessions. Okay. So now, okay, what left circumflex is going to supply? It's going to supply mostly your which aspect of your heart, that is your left atrium. Okay. Now lies the concept of dominancy. So what is dominancy, right? So basically the inferior surface is supplied by an artery, and basically what's the name of that artery? PDA. What do we mean by PDA? Posterior descending artery. In 80 to 85%, this PDA basically arises from your
Right
Right
coronary.
coronary artery.
right coronary artery. Perfect. But in the remaining 15%, it's going to be arising from your left coronary artery. But
Left
I
coronary
want you
artery.
guys to tell me. Hello? I want you guys to be telling me, would it arise from left circumflex branch or LAD?
LAD.
This codominant.
Diagonal.
Yeah.
Diagonal.
Left circumflex.
Yes, sir. Left circumflex.
Left circumflex. Remember, if an individual is left dominant, it means that the PDA, which is going to supply the inferior surface of your heart, is going to be arising from your left circumflex. One of your UWorld MCQ. Just note that down. Very high yield, okay? You guys should know this. Okay, so, okay. And we were talking about AV nodes. So now let's discuss. Okay, we also have a concept of codominance. What do we mean by codominance? Yes.
It means that the PDA will arise from right and from left.
Both from
From
right.
both.
Both
Left,
left circumflex and right coronary artery.
And the
Perfect.
patient will be the lucky one.
Yes, perfect. It's basically codominance. Okay. So for the AV nodal, you guys must know that the AV node itself have an AV nodal artery, right? And AV nodal artery basically arises from the dominant circulation. That is from the PDA, right? It arises from the PDA, and we know PDA itself depend upon the dominancy. If an individual is right dominant, it means that PDA is going to arise from right coronary artery. If an individual is left dominant, it means that it will be arising from the left coronary artery, especially the left circumflex. We know that, right? So AV nodal artery arises from PDA. And so can I say that AV nodal depend upon the dominancy?
Yeah.
Yes.
Yeah.
Perfect. It depends upon dominancy. You have a UWorld MCQ on that. You will be like in one UWorld MCQ, they are going to give you an individual with right dominant and another individual with left dominant. And then they'll be asking you from which coronary artery do the AV nodal arteries arising. So if in the left, it will be arising from left circumflex. The PDA, by the way, and PDA itself is arising from left circumflex. So these are the things which you guys must keep in mind. Okay. So let's just refer towards our slides. Okay. Coronary artery anatomy. We have right coronary artery. It's going to supply majority of right side of your heart. Along with that, SA node, we already discussed that. We have left coronary artery. It's going to supply majority left side of your heart. We already know that. We have LAD. LAD is going to supply 2/3 of interventricular septum, anterior lateral papillary muscles, and anterior left ventricle, right? Then we have left circumflex. It's going to give rise to posterior lateral left atrium and anterior lateral papillary muscle as well. We discussed posterior descending artery in 85% cases come from right coronary artery. And in the remaining 8%, like it's going to be like left dominant and 7% codominant. You already know the concept. It's going to supply the inferior border of your heart and the posterior 1/3 interventricular septum. Remember that. And posterior medial papillary muscles. So for the PDA, just remember it's posterior medial. The P and the D should indicate that it's posterior medial, DL, okay? PDA. Just remember it like that. Very important. You guys are going to see a lot of MCQ in your U1. So here is the anatomy. You guys can see. You guys can just see the pictures that you have your left circumflex branch, your LAD, your right coronary artery, and the marginal artery. This is going to be the posterior aspect of your heart. That is your posterior descending artery arising from the dominant artery. Again, we have an NVME MCQ this time. Who is going to participate in this discussion? Please raise your hands. Okay. Dr. Nairobi. Nairobi, can you just please turn on your mic? Perfect.
Yes, sir.
Yes. Can you just please read this MCQ and can you just please tell us what's happening and what should be the answer?
A stenotic region is identified in one of the coronary vessels just before the origin of the artery supplying the atrioventricular node. Which of the following arteries is most likely affected?
Yes. Just read this MCQ from the beginning now.
Yes, sir. A 66-year-old man comes to the hospital due to sudden onset chest pain and dyspnea. The patient has a history of asthma and gastroesophageal reflux disease, but says his current symptoms feel different than what he usually experiences. And ECG is consistent with ST elevation, myocardial infarction, and an emergency cardiac catheterization is performed. Evaluation of the left and the right coronary arteries reveals left dominant circulation.
Left dominant circulation. Perfect. Yes.
Yeah.
Right coronary artery.
Left,
Okay, yes, left dominant circulation, just not that point. Now just read the MCQ further.
Left
circumflex.
Left
circumflex artery.
Please be patient. Please just raise your hands. I don't want to turn off your mics because I want an interactive session. So please just stay humble. Those who want to participate, please raise their hand. It's an MCQ for Dr. Nairobi. So let her do this. Yes, Dr. Nairobi. As we discussed, he's left dominant. And we know that in left dominant case, the PDA is going to arise from left circumflex, right? And further, the AV nodal is also going to arise from the dominant. So what do you think the answer should be? Yes, Dr. Nairobi. Hello? Okay, anyone else? Please raise your hands. Dr. Olga. Dr. Olga? Left circumflex artery. That's perfect. Okay. So you guys are like doing great. Yes, you guys are doing great. So now we'll be discussing a few topics within the physiology, and then our time for, like we only have like, I would say that 13 minutes remaining in this session. So let's discuss a little bit physiology as well. Okay. So before discussing physiology, you should know some terms which are very important, right? The physiology itself for cardiovascular is a little bit confusing, but at the same time, it's very high yield and very important, right? So the first term which we are going to discuss is stroke volume. So what is stroke volume? If I just ask you what is stroke volume, just tell me as simple as you can. So your answer should be that it's the amount of blood which is leaving your heart in a single beat. Like, it's a simple definition. For example, if this is your heart, this is your aorta, interventricular septum, your heart. What is your stroke volume? If your heart is having a single beat, one beat, so the amount of blood which your left ventricle is pushing in your aorta in the single beat is known as stroke volume. How simple is that, right? But you have some other definition of stroke volume as well. We know a concept like that. For example, if this is your heart, right? We are going to have two phases. One is your systole and other is your diastole. What do we mean by systole? When heart is contracting, when it is ejecting your blood, that's systole. What is diastole? When heart is relaxing, when it is accepting the blood from your left atrium, that's basically your diastole, right? So we know that. For example, if you have diastole, what happens in diastole? As we know that the blood is going to fill within your left ventricle. And as the blood is filled, as the diastole end, so the amount of blood at the end of diastole, which is present in your left ventricle, is simply known as end diastolic volume, right?
Yeah.
The amount of blood which is present within your left ventricle at the end of your diastole is known as end diastolic volume, right? But after the systole or diastole, what happens? We have systole, right? So in the systole, what happens? As the heart contract, it's going to push stroke volume in a single beat, right? So this volume is going to be decreased. But as this volume decreases, then we are going to have, like, let's suppose that this much volume is ejected, right? Right? So at the end of systole, the amount of blood which is remaining in your left ventricle is basically known as end systolic volume.
Wow.
Right? Right? And systolic volume. So, okay, we know one of definition of our stroke volume. We discussed that the simplest definition for stroke volume is amount of blood ejecting within one beat, right? I can also just tell you another definition of your stroke volume. As we know that after systole, this amount of blood is leaving your heart. So it can be same as stroke volume. So can I write it down that stroke volume is equal to end diastolic volume minus end systolic volume? Can I say that?
Yes.
Yes, sir.
Perfect. If I just, take your end diastolic volume, if I just, remove the end systolic volume, you will be left with this amount of blood, which basically your heart is pumping in a single beat. So now we have two definitions, right? We have two definitions of your stroke volume. Now you don't have to memorize the mathematics. Believe me, right? There is a lot of mathematics. We are going to make sense of that because your USMLE wants you to have the concepts. If you guys need a detailed lectures, a detailed follow-up, so you guys can just join the marathon session, okay? So in the marathon session, basically this workshop is also conducted by the marathon team. I'm in the marathon team as well, okay? So if you guys need a detailed overview, just join our marathon. And those who want the details of marathon, just ask Dr. Hamza, and we promise you that we'll be just, helping you till the end of your match, not only for step 1, okay? And we have a lot of success stories. You can just follow our Instagram page. You can just see everything there, okay? Thank you so much. So let's discuss our next concept, that is ejection fraction. As we know that we won't go into, the mathematics, we are going to make sense of the things. What is ejection fraction? As the name indicates, ejection fraction. It is the amount of blood or the fraction of blood which is ejected, right, from the overall volume. Are you guys getting me? The fraction of blood which is ejected from the total volume. So we know that at the end of diastole, what is the total volume? That is end diastolic volume, right?
Yes.
Yeah.
Hello?
Yeah.
And what is the ejection?
Yes, sir.
So what should be the ejection fraction? The fraction which leaves, that was stroke volume, right?
Yes.
Hello? So can I say that it's basically stroke volume divided by end diastolic volume? And here you can just put the stroke volume variables. That is, are you guys getting me? Ejection fraction, the amount of fraction which is being ejected in a single beat from the overall volume. We know that the overall volume was end diastolic volume, and we know that the amount which is ejecting was your stroke volume. So can I say that ejection fraction is equal to stroke volume divided by end diastolic volume? But we know that the stroke volume is also this. So let me just put in end diastolic volume. The ejection fraction is equal to end diastolic volume minus end systolic volume divided by end diastolic volume. I think that now these mathematical equations are making more sense, right?
Yes.
Hello?
Yeah.
Okay, that's perfect. Okay, so let's discuss our CVS physiology. Let me just refer to the slides. So we were discussing about stroke volume, and we have preload. Okay, what is preload? Okay, let me just discuss another important concept as well, as we have only 7 minutes remaining in this workshop. So let me discuss a very important term of your physiological concept. Okay, so remember, we have a mechanism which is known as Frank-Starling mechanism, right?
Yeah.
You guys know that.
Yeah.
If you're just
Yeah.
getting, if you're okay, what basically Frank Starling mechanism means? It means that as we increase the volume of blood within the heart, the contractility of the heart increases. All of we know that, but we do not know the concept. Why? Right? We suddenly want you to know that why. You know, why does increased blood volume increases the contractility? So for that, in order to find out the reason why, we have to just, you know, go a little bit microscopically, right? We know that heart is a muscle, right? And we know that muscle is made up of actin and myosin filaments, right? So we know that if these are your actins, your myosin filaments basically are going to have an overlap with your actin. So right after overlapping of actin with myosin, the muscle is going to generate force or power, right? Hello?
Yes.
Yes, sir.
So can I say that the power of muscle depend upon the overlap of your actin and myosin? Can I say that?
Yeah. Yes.
The power of your muscle depend on, you know, like cross-linking or overlapping of your actin with myosin.
Myosin.
So remember, the Frank Starling basically comes from here, the Frank Starling mechanism. For example, if this is your heart, if I'm just filling your heart with more blood, so with more blood, if you zoom in the picture, if you just look microscopically, with more blood, you have more actin and myosin overlap. You have more affinity of actin and myosin. Now, if you have more affinity of actin and myosin, it means the power of your muscle increases. If the power of muscle increases, it means contractility increases. So from now onwards, you don't have to, you know, like memorize things. You guys should know the concept why. Is that clear?
Yeah.
Yes.
Perfect.
Yes.
Okay. So we discussed end diastolic volume. So now can I say whenever the end diastolic volume increases, contractility will increase. Can I say that?
Yes.
Yeah.
Why?
Yeah.
Because the
Because it
power
creates
increases.
tension.
Because the power increases. Why does the power increase? Because we have maximum overlap of actin and myosin, right?
Yes.
Yes.
If the contractility increases, if the power increases, what happens to stroke volume? What do you guys think?
It will increase.
More powerful main increase. Perfect. Now you guys know the entire things. You guys know the correlations, right? Let's discuss another term, that is afterload. Afterload. So looking only towards the name, you should know what is afterload. It is the load against which your heart is pumping. The load after your heart, right? Afterload. Like this is your heart, this is your aorta, right? So for example, the amount of load which your heart is pumping against is basically your afterload. Am I right?
Yeah.
Yes.
Hello?
Yes.
Looking towards the
Yes,
name,
sir.
afterload is the load
Yes.
against your heart. Okay. So how do we get this load?
Contracts
We
it.
already know that, right? We have our blood vessels, right? Our blood vessels. We know that in the blood vessels we have arterioles, right? If the diameter of the blood vessel is increased, what happened to the resistance? Increase or decrease? Yes, that's simple. Decrease resistance, right? So as the diameter increase, now the blood can easily flow. If the blood can easily flow, it means we have less resistance. While on the other hand, if the diameter of your blood vessel decreases, what would happen to resistance? Resistance will
Increase.
increase. Why? As we have less diameter, now less blood can flow, there is more resistance. If we have more resistance, can I say that we have more load?
Yes. Yeah.
Can I say that if we have more resistance, we have more afterload, now our heart is going to pump against more load. Or in other words, I would say that, for example, these are your dumbbells which your heart is going to, you know, lift up, right? So if I'm just decreasing the diameter, what happens? It's same as I'm just increasing the, you know, the kgs of dumbbells, right? Now I'm giving, like, you know, for example, if it was 10 kg dumbbell your heart was lifting, Now I'm giving it 20 kg dumbbell. It means now the load is increased, right?
Yes.
Yes.
Okay.
Yes, yes.
So I want you guys to tell me in which condition we have chronic decrease of our diameter.
Aortic
Hypertension
stenosis.
and
Hypertension.
aortic.
Hypertension.
Hypertension.
Aortic
Hypertension.
stenosis.
Hypertension
Perfect.
Hypertension,
and
stenosis.
hypertension.
Hypertension and stenosis. So can I say that individual having hypertension or aortic stenosis means same as now the heart is going to lift like more weight dumbbell, right? Can I say that?
Mhm.
Yes.
Yes.
Perfect. If now the afterload is increased, now your heart have to lift, like a 20 kg dumbbell. So for that, your heart needs muscles, right now?
Yeah.
Yes.
Like for example, if I have two bodybuilders, right? One is, like a weak bodybuilder and a strong bodybuilder. So only a strong bodybuilder can just lift more weight. That's simple. So if you
Yes.
have, like if chronically your heart is lifting more weights, it means that muscle is going to grow. We know that, right? So this growth of muscles can be in two forms. That is,
Hypertrophy.
that's basically known as hypertrophy, right?
Hypertrophy. Yeah,
Hypertrophy.
yeah.
And the hypertrophy which you are going to see here is concentric hypertrophy, right?
Mhm.
And what is
Exactly.
concentric hypertrophy?
Yes.
That now your heart is going to, put down more muscles in order to bear this afterload. Is that clear?
Yeah. Yes, yes.
Perfect. All of the concept which we discussed, let's just refer towards our slides, okay? Okay. So we discussed stroke volume, we discussed preload. What is the preload? The end diastolic volume is your preload, right? Preload and afterload. Okay. So we discussed that as the preload increases, as the end diastolic volume increases, now we have maximum overlap, so the contractility would increase. For the stroke volume, we discussed it can be written as end diastolic volume minus end systolic volume. We know that. For ejection fraction, we know it's stroke volume divided by end diastolic volume. We know as the preload increases, end diastolic volume increases, stroke volume increases. Why? Maximum overlap, Frank-Starling mechanism, like, pushing a lot of stroke. We discuss everything, right? What is your afterload? Afterload is against the load against you, which your heart is basically acting. So in two conditions, as we discussed, that is an aortic stenosis, afterload can be increased, and chronic hypertension, afterload can be increased. And as a result of that, what would happen? Your heart is going to lay down more muscle, right? That is concentric hypertrophy. You have a word MCQ on that. Keep that in mind, okay? So for the contractility, sympathetic nervous system also helps, right? So you have beta-1 receptor on your heart. We know that as the beta-1 receptors are stimulated, so it can increase your contractility and the stroke volume further can increase, okay? So the time is finished. We will be continuing our session tomorrow. And like we have like exact time. Those who want to have such kind of detailed sessions with us in the marathon, so you guys can just contact Dr. Hamza, and everything is going to be discussed in the same way with you guys the lectures. And for this workshop, in the end, we are going to have an assessment. Those who just cleared assessment, they'll be having chances to get into our marathon, okay? So just focus on today's the workshop, and in the end, those who just did assessment, we are going to give you our certificates in the end as well, that you guys have attended our session, okay? So let me just mention our NEXTGEN platform is registered within the Texas. So it's a big platform, believe me, right? Currently, we have 5,000 students who are preparing for their USMLE steps, and we are working day and night in order to help you guys, okay? Thank you so much. Those who are interested in the marathon, do contact Dr. Hamza. Thank you so much. Thank you. Have a nice day and see you tomorrow. Bye-bye.
Thank you so much.
Sir, I have a doubt.
Yes, please.
Sir, why most of the patients are asymptomatic in case of patent foramen ovale?
Okay. In case of patent foramen ovale, why most of the patients are asymptomatic? That's a good question. So
Because of its size.
Yes. Anyone who want to answer?
That P4 is small, so the hemodynamic effect will be later. Will come, but it will come so later. According to the age, after maybe 5 years or 6, it is different. It depends on the physiological physiology of the body, but it depends on the size.
Okay. Okay, that's a good explanation, but let me explain as well. You know that in patent foramen ovale, basically we are going to have like, a communication between atria, right? Okay, let me just draw it here. Everything is going to be so simple, okay? Okay. So we know that we have our atria, right? So patent foramen ovale is basically a communication between your atria somewhere here, right? Are you following me? Hello?
Yes.
Yes. Yes, sir.
Yes, and normally we know that the left-sided circulation are more as compared to right-sided circulation pressure, right? So the left pressure is more as compared to right side. So in the left side, we have oxygenated blood, right? So if the oxygenated blood is mixing within the deoxygenated blood, you won't see any cyanosis. Cyanosis is only seen whenever the deoxygenated blood mixed within the oxygenated blood. Is that clear? As the pressure is more on the left side, so by no chance you have like, mixing of deoxygenated into oxygenated, while you have oxygenated being mixed within the deoxygenated. So now no cyanosis being seen.
Okay,
Hello?
sir.
Is that clear?
Yes, sir. I
Perfect.
Yeah,
understood.
yeah.
Can you
Okay.
Sir,
explain
one
once
more
more,
thing.
sir?
Sorry?
Once more, sir. Once more.
What is?
Can you explain again, sir?
Okay, I'll just explain it. Okay, let's go in a little bit more detail. No problem. Okay, so as we know that after the birth, left-sided pressures are more, right, as compared to right-sided pressure. You know that, right?
Yes.
Hello. Like for example, if this is your heart, okay, I'm just only drawing the atria. Okay, just sorry for the ventricles. Patent foramen ovale is basically connection between your atria, right? So here you guys can see the left-sided pressure are more and the right-sided pressure are less. We already know that fluid moves from high pressure to low pressure. Fluid do not move from low to high pressure. Am I right?
Yes.
Yes.
It means that, okay, we already know that at the left side we have oxygenated blood. It means that the oxygenated blood is mixing within the deoxygenated blood. Is that right?
Yeah,
Yes.
yeah.
Yes.
You want to see cyanosis. Cyanosis is only seen whenever the deoxygenated is entering into your oxygenated.
Oh,
When
Is
the
that clear?
shunt become right to left.
Yes. And how do the shunt become right to left? Is the Menger syndrome. That's going to be a
Yeah.
topic for tomorrow. Thank you so much. Okay, so we have limited seats
Sir,
remaining for
one
our
more thing.
marathon. Yes, please.
So
Yes.
what is cryptogenic cerebrovascular accident?
Perfect. Cryptogenic cerebral. Okay. Did you attended our lectures yesterday?
Yes, sir.
Okay. So what is cryptogenic shock? As we discussed yesterday, we were discussing a concept that DVT, if we have pattern foramen ovale, right? Let me just explain it in detail. Okay. So those who just missed yesterday lecture, it's a kind of review. Those who have missed, just kindly watch our YouTube video. We have already uploaded, but let's just discuss it here. Okay. For example, if you have pattern foramen ovale, right? Hello? Hello?
Yeah.
Yes.
Yes,
Yes,
sir.
sir.
Okay, this is an individual with PFO. And let's draw another individual heart, which is normal, right? So for example, if it's a normal heart without having any PFO, right? Let's suppose both of these individuals develop DVT, right? Deep vein thrombus. Virchow triad is satisfied. We have deep vein thrombus. And by any chance, if this deep vein thrombus just moved, like in this normal individual, it would get into right atrium. From the right atrium, it can get into right ventricle. From the right ventricle, it would just get into lungs, giving you pulmonary embolism, right?
Yes.
Okay, perfect.
Yes.
But in this individual having PFO, if you have same event, that is the thrombus can move here and it can have chances to directly go into your right sided, left-sided circulation, right? From the left-sided
During the
circulation, this thrombus
Valsalva.
can enter into your left ventricle. And here it can enter into your aorta, right?
Yeah.
Right? And aorta basically give branches to your CNS as well, right? So sometimes this thrombus can go into the CNS. It can cause stroke. So the stroke, which is caused by this entire mechanism, is known as cryptogenic stroke.
Sorry,
Oh,
sir.
yeah.
Okay, sir.
Sorry, sir. But normally from the right side, it couldn't go through the left atrium because
Yes.
the shunt is left to right, not right to left. But
Okay.
during a Valsalva, making a Valsalva,
Yeah,
because
that's a good point.
yeah,
That's a good point.
the blood coming a lot to the right side, then the left side. The left side pressure will be down. So during a Valsalva, especially in the strenuous phase, it will happen, I think.
Okay. Okay. Yes, that's a good point. Like, you guys should be asking me a question. That, sir, how do the thrombus move from right side to left side? Because you told us that left-sided pressure are more and right-sided pressure are less. This should be your question. Why didn't you guys ask me this question? Hello?
Yes. Yes, sir.
Yes, sir.
As I told you, the left-sided pressure are more, right-sided pressure are less. So the fluid always moves from high to low pressure. But in this cryptogenic stroke, what happens? We have opposite flow of thrombus and blood. Why didn't you guys just ask me that question? So the answer for that is that you have Valsalva manure. What is Valsalva manure? If you are sitting or if you are just, with closed epiglottis, if you are just blowing into your chest, what happens? The pressure at the right side basically increases in that. Remember, right? Why? Because as you're pressing against your closed epiglottis, as you're making more pressure within your chest, as you're just making more pressure within your chest. So what happens at that time? What happens that all of the veins present within your chest are going to constrict. And as those veins constrict, they are going to put more blood into your right atrium. As we have more blood into your right atrium, so now what happens? The right-sided pressure increases as left-sided pressure. Now this thrombus can move during Valsalva maneuver, especially during the strain phase. It would just move into your left atrium and it would just cause this problem. So this was all for today, and we have limited seats remaining in our marathon session. If you guys are interested, just do contact Dr. Hamza for that. And thank you so much and have a nice day. Bye-bye.
Thank you, sir.
Thank you so much, sir. Thank you.
Thank you, sir. Thank you.
Thank you so much, sir.
Thank you.
Thank you. Thank you. Thank you, sir. Thank you, sir.
Will we be discussing
Thank you, sir.
ECG?